Hello, and thank you for joining today's special webinar titled Challenges in Molecular Testing. In this installment of the Community Connections Health Series, Dr. Luis Raez, Chief Scientific Officer and Medical Director at Memorial Cancer Institute, will share insights on the complexities of molecular testing, common barriers patients face, and how to navigate this essential step in personalized cancer care. This session is proudly presented by Memorial Cancer Institute. My name is Oneida McEachin, and I'm with Memorial Healthcare System and Memorial Cancer Institute, the presenting sponsor for today's session. We are excited to be partnering with the American Lung Association on this cutting-edge topic. I will also be today's moderator. Before we get started, I would like to share a brief video illustrating MCI's commitment to research and clinical trials.
We hope we never meet you. We hope you never need our chemo room or groundbreaking research. We hope our specialists never know your name. Though our treatments and technologies are advanced, we hope you never need them. At Memorial Healthcare System, we hope you're never diagnosed with cancer. But if you are, you won't need to hope for exceptional care. It's right here. Memorial Healthcare System. Hope lives here.
With that, I'd like to introduce to our presenter, Dr. Luis Raez. He is a leading hematologist and oncologist at Memorial Cancer Institute, where he serves as the director of the Thoracic Oncology Program. With more than 2 decades of experience treating lung and head and neck cancers, Dr. Raez is a renowned cancer researcher and educator. He designs clinical trials, advances cancer vaccine research, and teaches at multiple universities, including Florida International University and Florida Atlantic University. He is currently the president of the Florida Society of Clinical Oncology and an internationally recognized voice in cancer care. Welcome, Dr. Raez.
Thank you very much for the introduction. And also thanks to American Lung Association. We have a great partnership with this great institution for many years, and we're always very happy here to try to help, to educate, and increase advocacy efforts to fight against lung cancer. Basically, these are our disclosures. So we do clinical research with a lot of these industry partners. This is I put the title as a challenging because there is a challenging when we have to learn a lot of new things. For years, as you can see in the orange, we were doing what we call germline molecular testing, meaning genetic testing. If you remember, the best example is the BRCA2 gene for breast cancer. That we like to check if the patient has the gene, if the mother has the gene, if the daughter has the gene, so we can try to prevent future problems with the cancer coming in the relatives. And we also have in colon cancer, the one called Lynch syndrome, that unfortunately is a gene that passes from the grandparents, parents, and sons. What we talk about today is basically in blue is what we call somatic. We don't call germline, it's the tumor genetic. Yeah, it's the somatic mutations or evaluations we do in the tumor. That's why for our lung cancer community, this is the relevant one. We haven't been unable to prove that we have genes that are transmissible, like the germlines in orange. So that's why all of the genes that we're discussing are always somatic. In the blue, the good news is because they are somatic, they are genes that belong to the tumor, they are not inherited by our relatives. So meaning that lung cancer, we haven't been proved yet that it's hereditary. Yeah, so that's a good thing. In the future, because in some diseases like breast cancer, both situations now, in breast cancer now, we not only have now germline genes, we also have somatic genes. Probably the solution for the future is do only one testing in every cancer patient, including lung cancer, to check everything, everything that is hereditary, everything that is not hereditary, everything that occurs on the tumor. So it will be only one test that we will do in all the patients. The other problem that we have is that there is not enough tissue. That's why we need your help to educate providers and make patients aware about that. Sometimes patients feel frustrated because there is not enough tissue to do this genetic testing. But what we show in this publication is that it's very important that when our pulmonologists and surgeons do the bronchoscopies to do the biopsies, they need to do several biopsies. So the idea is as more tissue we get in the biopsies, higher chance of success, and we can solve this problem, you know. That's why we do, for example, 6 passes. So 6 small biopsies, we can find molecular testing, we can do molecular testing in 95% of the patients. Yeah, but if you see, we do maybe 3 or 4 passes only, we only diagnose 77. This is very important because if we do not have tissue to do your molecular testing, you may be missing the opportunity to have precision medicine therapy, target therapy, to have a pill specific that works for you, and you will get having conventional chemotherapy or immunotherapy, and the results are not the same. Yeah? Talking about the markers, the first markers that we're going to talk about, somebody asked me that question in writing before the seminar, is about immunohistochemistry. You know, the most popular marker, I guess, for lung cancer to classify the tumors in the PD-L1 marker. It's immunohistochemistry, meaning in the tissue, in the slide that carries the tissue or the biopsy, we do a stain. That's called immunohistochemistry, and the most popular one is the PD-L1. So basically, with the stains that we do, the PD-L1 testing and the molecular testing, the genetic testing, we classify, for example, lung cancer patients in this way. So, for example, all the metastatic lung cancer patients can classify in target therapy in the left if we find the gene. No, we do the genetic testing, we find a gene. You had a gene EFR, ALK, ROS, RET. We have in total 10 genes, but we only put 3 to make it easier. So 25% of the patients, thanks to the molecular testing, are classified and they can get filled. Downstairs, we use the PD-L1. If it's high, no, this staying in the tissue, you can get only immunotherapy. Pembrolizumab is the first one. And in the right, close to half of the patients with lung cancer today, they don't have this PD-L1 high. They don't have the genes, so they have to get chemo and immunotherapy. You know? So that's a way to class it. That's why this molecular testing is very important. We want you to be in the right pocket. We don't want to miss opportunities for you, especially if you can have target therapy, because we discovered a gene that we call actionable, meaning because we can have a treatment for that. You know, we have already approved drug for that. And this is an example why there are challenges, because it's not as easy, you know. So somebody was asking me about the immunohistochemistry in the questions. Look at the tumor in red. If we do a biopsy on top of the tumor, you see this white color. The PD-L1 is negative. If we do a biopsy in the low portion of the tumor, you see that strong brown. The PD-L1 is positive. No, and then the PD-L1 change. Look at the right. Look at the columns. You know, this is the same patient, but there are metastases in the lung, in the liver, in the adrenal, in the brain. You can see how the dots change, because depending where we did the biopsy, this marker PD-L1 can be high, can be low, and you're talking about the same patient. Even downstairs in the graphic, this is the same patient that is getting different treatments, and you see how the PD-L1 goes up and down the treatment. Now, that's why this is the marker that we use, but there is a lot of unmet needs. It's not perfect. It's far from perfect, and it's very frustrating sometimes for the patients and the doctors that we don't get the results that we want or we need. No? And why this is important, this is an example why it's important. This is if you do the marker, the PD-L1, and it's more than 50%, we can use immunotherapy alone. No? So in green, you have immunotherapy alone, pembrolizumab. In dark purple, you have the conventional chemo. So that's why, since that we discovered this marker PD-L1 and we use immunotherapy in green, now you can see that 5 years later, more than 30% of our patients are still alive and fighting thanks to the immunotherapy without the need to have chemo. That's why it's very important. If you are one of these patients that have this marker, we need to find it, because we can avoid to give you chemo, and you can have this result only with immunotherapy alone. No, so that's why it's a very good example why. But we have other markers. I'm going to mention only one because I don't want to confuse too much. That this is a popular one, is the tumor mutation burden. It's mainly, we can say that we are counting here the bulk of mutations. So how many mutations, how promiscuous is the tumor that has a lot of genetic aberrations. So as more genetic aberrations the tumor have, we call them more higher tumor mutation burden. You know, as lower genetic aberrations the tumor have, it's a lower mutation burden. And we discovered that this mutation burden, is associated with response to immunotherapy, because we were saying, oh yeah, if you have a lot of mutation burden, a lot of these genetic aberrations, you're probably going to do well with immunotherapy. But it's not necessarily like that, you know. For example, you can see in the right in these graphics, all the black ones that are better results in survival or progression-free survival, it have high tumor mutation burden. All the ones in orange that have lower results are low mutation burden. No, so you can say, oh, you discovered a new marker. Now we really need to apply this concept. The problem is in the left. What do you call high tumor mutation burden? There is no harmonization. Depending on the researcher or the institution, the definitions are different. So there may be something for you that is a higher tumor mutation burden. For me, it's a lower one, and et cetera, et cetera. So that's why I was telling you that there is challenging. So this marker, we can't use the marker because there is not an agreement on what is high, what is low yet. And this is, for example, another test, another biomarker. You know, this is a test. This is not in the tumor, it's not in the tissue, this is in the blood. You know, we check proteins in the blood. There is a number of proteins in the blood that we think that are associated with response. So if you have the proteins, you will respond to chemo. You know, so that's basically you look in the right side, blue versus light blue versus dark blue. The patients with immunotherapy alone, ICI is immunotherapy alone, they don't do very well because they don't have this protein. So we need to add chemo in light blue to improve the survival, you know, because they don't have the protein. On the right, the test is negative. This patient doesn't carry the protein, so the only way to improve the response is to add chemo. In the left, if we use chemo or no chemo, doesn't matter because the patient has the proteins and say, hey, this is going to do well with immunotherapy. But you can see that the immunotherapy alone in dark blue versus the immunotherapy plus chemo in light blue is the same result. Yeah, that's why this is another marker or test that we can use. Hopefully, it's already FDA approved to improve the outcomes that we get in our patients and to guide therapy better. No? Now we're going to talk about the mutations and the precision medicine, the field, the target therapy. Why this is very important, you see in the right, 20 years ago, we only have 4 types of chemo. The only thing was chemo. There was no immunotherapy, no target therapy that you see the outcome. Pretty much the survival of the patients at 4 years was minimal because the chemo used to only work for 2 or 3 years and then it failed. And you can see it doesn't matter what chemo we use, all the colors go to the same direction. Now you see here in the left, we have no immunotherapy and target therapy. This is a region called mariposa. We use an immunotherapy called amivantamab and a pill called lazertinib. And this one, you see the result is better than the osimertinib alone is a pill. But doesn't matter, any of these 2 regimes, either the one in blue or in gray, you can see that at 4 years, of getting 4 years, the survival is 3 or 4 or 5 times the survival we used to get with the chemo along in the right. So that is why discovering this target therapy, the genetic aberrations, now we can do a much more rational therapy that can markedly improve, as you can see, the survival of our patients. And this is important. Also, that's at the beginning. When you have a new patient with lung cancer, we need to classify the lung cancer based on the genetic aberration, the mutations that the tumor has. But another important concept that we need really your help is that this molecular classification, this genetic analysis, this needs to be repeated. It is not only done one time in the life of the patient. And why is that? Because when this is a patient, for example, that has a genetic aberration called EGFR, the patient is treated. Now, when the treatment fails the patient, and now the tumor is growing, the tumor may be still EGFR, like in purple, but they develop all of these weird genetic aberrations that are with different letters in the bottom. Or the tumor can change. The tumor switch is not an EGFR tumor now. As you can see in the second bucket, is a MET tumor now, or it's a HER2 tumor. Or in the third graphic, the tumor switch. This used to be an adenocarcinoma of the lung, now it's a small cell lung. So that's why we need to repeat the testing, the molecular testing, because the tumor may evolve, may switch when it becomes resistant. So now the treatment, if you want to do a rational treatment, as we did at the beginning, we need to know what is happening now. And these are examples. No? This is a research that we published with a consortium that we have in Memorial. These are results in more than 3,000 patients. And you can see in the right, all of these funny numbers, 797, 718, 724, 721, these are new mutations that were not present before that are coming. And these mutations are resistant to the original therapy of these patients. And in the bottom, you see the new ones. Not only the number ones, but also, I was telling you before, there are other names, like a CMET, PT53, CTN81. So there are different mutations that are coming that we need to know, so if we want to do another target therapy. Now I want to give you an example, okay, about resistance, because there was a question about resistance, so we wanted to know about resistance. This is a real case of a 39 patient that came with bilateral pneumonia. As you can see, we thought at the beginning that this is a lady with bad lungs. She probably got a pneumonia, but for a 39-year-old to have such a severe pneumonia, you see, normally black, and now we're seeing white. Very, very rare, that somebody has such a bad pneumonia, and the patient was dying, so they wanted to put a hospice care. But anyway, to make the story short, we tested her in the blood, because we also do liquid biopsies. We look for these genetic aberrations in the blood, because we can catch the DNA of the tumor swimming in the blood. And the patient has what we call an ALK fusion, ALK. It's a very important genetic aberration, because we have 5 pills for it, and they respond very well. To the point that they wanted to send the patient to hospice, and we asked them to please give us a chance, because usually these patients respond very well. And that was the case. Before treatment, in the middle, you see that after 6 months of therapy with a pill, it's an oral agent, alectinib, the patient was doing much better. And 9 months, she was clean. With the PET scan in the right, it looks like the patient is clean now. And after 30 months, unfortunately, the patient developed resistance. And how we know they're resistant? Because we repeated the test. We repeated the test in the blood and the tissue. We found that the patient now, in the bottom, you can see there are some funny numbers, ALK 11, 17, A1. This is a resistant mutation that the original agent that we gave for alectinib doesn't work anymore, but no problem. You see here, this is a table that shows different pills on top that work for the genetic aberration that are approved, and all of these weird mutations in the left column in white that they develop. All of these guys are new. All of these mutations come after therapy, because the tumor changes and tries to become resistant. What we found in the one column before the last, brigatinib, that you can see in the patient profile is the one in purple, that the green is good, green is still sensitive, so we give her that agent, brigatinib, because we know that now there is sensitivity to this pill, despite the fact that the patient has failed in the next one, in red, alectinib. And it was successful. The patient responded another 10 months before she developed resistance again, and then we give her another agent, and now, thanks God, she's doing well for more than 5 years with no evidence of disease. Yeah. The other thing that we can do is we also can do testing, genetic testing for the budget. I already show you examples. We're discovering genes that we can use it for treatment. But there are other genes that we don't have treatment yet, but we know that they are bad. and we can prevent, and we can do something about that. So these are genes are called, these are bad genes, STK11, KEAP, and P53. If you see in the bottom, in this case, we check the genes in patients, and this is a very large study of more than 80 universities in the United States, including Memorial. I published this because it's a very important one. In the bottom, you see when the patients have the genetic aberration in orange, KRAS, STK11, and KEAP, all of them in orange. You look at the right, the survival is KTL, is the last line, is only 8 months. If you're giving these patients the standard of care, the best immunotherapy that we have, they only survive 8 months. So that's terrible. That's the same outcome that we used to get 20 years ago with chemo only. But this is because the genetic aberrations are bad. They are resistant to immunotherapy. You see on top of the same table in the right, if the patient only has KRAS, but it's not as bad, the survival goes up to 23 months. So that's why it's very important to find also the genetic aberrations, because we know that immunotherapy may not work. Here we have now regimes. So this is a study that shows basically there are 2 drugs here in immunotherapy. It's called tremelimumab and durvalumab. That in the right upper, you can see the response rate is much better than the ones that we get with conventional immunotherapy. No, this is another example again. If we are using this another 2 immunotherapies, nivolumab and ipilimumab, these immunotherapies are not resistant and they can work and have a better survival. You see the light blue is better, thanks to we're using 2 immunotherapies that are not the conventional one. Finally, we need to test everybody. We already give a lot of examples on stage 4. This is stage 1 to 3. This is after surgery. This is the famous Adaure study after surgery. If you have an EGFR mutation, and we'll give you osimertinib, you can see that the survival is much better. At 5 years, there is a 10% more people alive thanks to the osimertinib, because we give you therapy instead of observation, the yellow curve is observation. And the same happened after chemoradiation. Now, all of these patients on stage 3, in this Laure study, they get chemoradiation, standard of care. After the chemoradiation, there is a success. But what happened after chemoradiation, if we don't do anything, you can see orange, pretty much everybody relapses. And this, I know, the progression-free survival, everybody progresses. But if we give you the pill because you carry the genetic aberration in EGFR, you will do much better than you know. So the final topic to finish is the ctDNA. This is the liquid biopsy that I was mentioning that we can do in many stages of the evolution from the patient. These liquid biopsies are as good as tissue. So if you cannot get the tissue, don't give up. Do at least the liquid biopsy. What we show in this research that we did is that they are equivalent, and we use liquid biopsy 74% of the time to make treatment decisions. Why we use 74% of the time? Because they come in 9 days. If you see in the right, in 9 days, we have a result of liquid biopsy compared with 28 days of the tissue. So for us, in 9 days, we can make a decision for you with treatment thanks to the liquid biopsy. That's also important to do it. And finally, what is new is that we can detect the DNA in the blood. So we can track the tumor. And as you can see, in the right side, there are patients that have no DNA in the blood, they survive. You can see the black curve, patients that are carrying the tumor in the DNA that we identify the DNA in the blood, they don't do very well in orange because we know that they still have cancer. And there are several technologies, tumor naive, tumor informed, all of them show the same thing. So this is a real study. These are patients that after surgery, they receive immunotherapy, and you can see that all of the ones in blue, that they got immunotherapy, and they did better than the ones that didn't get the immunotherapy. But you can see that the patients that are ctDNA positive, they did better, and the one that is available in ctDNA negative, even if you don't see a tumor with immunotherapy. Finally, this is the same thing. You look in the left, it sounds complicated, but it's not. It's basically if the ctDNA, the tumor DNA increases in the blood, and the chest X-ray shows that the tumor is growing, that's the blue one, the survival is very bad. On the contrary, the red one, On top is the one that if the cats can say that you don't have a tumor or it's stable, and we check your blood and there is no cancer because the ctDNA disappeared, that you are going to have a very good survival. So, okay, this is becoming a standard of care hopefully soon. So we'll be using this in our treatment decision. Thank you very much for your attention.
Thank you, Dr. Raez. And at this time, we will turn it over for some questions. The first question we got was from Janice. If molecular testing identifies an EGFR mutation in one lung, but not in the other nodule in the opposite lung, would targeted therapy still be recommended?
Yes, because we still have to take care of the first lung, and then also it depends. If we get two lung cancers at the same time, synchronous, we need to investigate both. Because may be different, and the treatment may be different. When we have a lung cancer and later we develop other nodules, we can assume that probably they are coming from the original one and they are metastatic. So that's why, but when they are at the same time, we need to do biopsies in both because there may be early tumors that they may not necessarily be the same.
Okay, perfect. We have another question. This one is from Megan. She says, my question, Dr. Raez, is about repeating biopsies and biomarker testing after progression on the targeted therapy, such as TKI. Do you typically recommend a repeat biopsy at progression? If so, is tissue biopsy or liquid biopsy preferred? And do you also repeat biomarker testing? And would that include RNA-based testing or reflex testing?
Yeah, that's an important question. That's why I gave you the example of the ILK patient, because we need to be careful that when the tumor progresses, it may be already resistant. Because sometimes when there is a minimum progression, we give a little bit of radiation, or we try to keep with the same pill, with the same agent, because the oral agents are very well tolerated, and we try to keep our patients for years with the oral agent. But in the example that I showed you, that lady, after 3 years, the tumor was already resistant to the pill that she was taking, and we identified that thanks to we did an analysis in the blood and in the tissue when she progressed. So that we know that even giving a little bit of radiation or doing something else, it will not work. We have to change treatment. We were fortunately, as we put them in the example, that the next pill that we choose, the tumor was still sensitive, and we bought another 10 months until finally we give her another pill. So that's why it's very important to repeat the molecular testing. If it's not possible to do a tissue biopsy, because from cancer it's hard to do many biopsies, at least doing the blood. In the blood, we can identify sometimes the genetic aberrations that are progressive.
Thank you. All right, we also have another question from Mar. How do you prioritize immunohistochemistry testing when evaluating and guiding treatment decisions?
Yeah, the immunohistochemistry testing is what I explained, the stain in the slide, the PD-L1. We always need to do that test because it's very important to us, because for target therapy, oral pills, the mutation. But for the immunotherapy, we need the PD-L1 testing. And as I showed you in one of the first slides, we need both analysis to determine what is the best treatment for the patient. So we always try to do them all. And immunohistochemistry is easy. You only need 1 or 2 slides. Molecular testing is more complicated because the genetic analysis, you need 15 or 20 slides. That's why we need tissue. Maybe there is a little bit of tissue. We only need chance to do one of these studies. Immunohistochemistry is the easy one because you need less slides, less tissue.
Thank you so much for that. And our final question is from Roseanne. How important is the specific type of EGFR mutation when determining treatment with targeted therapies such as Tagrisso?
It's a very important question because, as you can imagine, these things are much more complicated than we imagine. When we discovered EGFR, we thought there was only one type of mutation. Now we know it's a family. Last time I checked, we have more than 18 types of mutation or something like that. Fortunately, most of the mutations are only two, the EFR exon 19 and exon 21, that covers probably 80–85% of the patients. And these are the ones that, because they're more numerous, we have more publications. For the rest of the EFRs, we have less publications because it's harder to find patients. So that's why the development sometimes are faster for what we call common EFRs, because they are numerous compared with the rare EFRs or common EFRs. Yeah, but the good thing is when you do this genetic analysis, this next generation sequencing, we check them all. So if you are one of the patients that has one of these uncommon genetic aberrations, we will find it. But the treatment is a little bit more challenging because, as I said, we have less agents that for the common ones, because we have been studying the common ones for now and going to be more than 15 years.
Okay, thank you. That's all the time that we'll have for today. For any questions that we didn't get to, please send them in the email in the chat or in the post-event survey, and we'll follow up with those answers shortly. Thank you again, everyone, for attending American Lung Association's communication webinar presented by Memorial Cancer Institute. Once again, thank you, Dr. Raez, for your insight on the challenges and importance of molecular testing in lung cancer care and why it plays a critical role. We hope that this information has allowed you to better understand how this works, why it matters, and how to advocate timely and for comprehensive testing. To learn more about Memorial Cancer Institute resources and the current trials, please visit the link in the chat. Additionally, the American Lung Association is committed to advancing research and the steps needed to defeat lung cancer. When you support the American Lung Association, you are supporting one of our great partners invested in this effort with us. Together, we can create a world free of lung cancer and lung disease. To explore the ALA's resources, tools, and ways to take action, please visit the link in the chat and on the screen. Don't forget to follow South Florida American Lung Association on Facebook for announcements regarding our next community connections and webinar events. Follow the ALA at Lung SOL for details. Until next time, thank you all, and remember, together we can improve one life, one breath at a time. Have a great day.